Welcome to the Deep Dive. We're the place you come to get the core insights from complex information fast. Today, we're diving into something really central to global health. It's the World Health Organization's brand new guidelines, just out this year, 2025, on managing arboviral diseases. And these aren't simple colds we're talking about. Think dengue, chikungunya, Zika, yellow fever complex, sometimes fast-moving infections. So our mission today to really unpack these new guidelines. Why now? What's actually new? And crucially, what does this mean for managing these diseases, whether you're, a healthcare provider or just someone trying to understand the bigger global health picture?
Exactly. And we'll get into what these arboviruses actually are, how they spread, and the real challenge clinicians face telling them apart, especially early on. We're drawing straight from this latest WHO publication. The goal here is standardizing care, improving outcomes globally. It's quite a look at how global health bodies adapt to growing threats.
Okay, so let's start right there. What exactly are these arboviruses and why the urgency from the WHO with these new guidelines now?
Well, the urgency is definitely there. Arboviruses are simply viruses transmitted by arthropods, mostly mosquitoes in this case, specifically Aedes mosquitoes, Aedes aegypti, Aedes albopictus. Traditionally tropical, subtropical, but they're moving. And these guidelines focus on four big ones: dengue, chikungunya, Zika, and yellow fever. The scale is, frankly, enormous. These AIDS-borne viruses threaten about 3.9 billion people right now.
3.9 billion. That's almost half the planet.
It is, and we're seeing this convergence, ecological changes, economic factors, social shifts, all pushing their spread globally. And the numbers are climbing. Dengue cases, for instance, they've roughly doubled each year since 2021. Think about that. Over 14.2 million cases reported to WHO in 2024. And tragically, over 10,000 deaths just from dengue last year.
Wow.
Yeah. And chikungunya, over 460,000 suspected cases globally in 2024. Zika is down from its peak in 2017, but still over 30,000 cases last year. And yellow fever, it's also reemerging, sometimes at these really explosive outbreaks. But here's a major challenge, the clinical differentiation part. Early on, these infections, they can look really similar.
Similar to each other.
To each other,
Yeah.
yeah. And also to lots of other things that cause fever. So getting an accurate diagnosis quickly is tough, especially, in places without easy access to advanced labs.
So it's a bit of a medical mystery at the start. How do clinicians even begin to tell them apart without those instant lab results? Are there clues?
Exactly. It's like putting puzzle pieces together. The guidelines actually highlight specific clinical signs, things you can see or measure at the bedside. So for dengue, look for thrombocytopenia, that's a low platelet count, plus a rising hematocrit, which is a concentration of red blood cells, and leukopenia, low white cells. Those three together strongly point towards dengue. For chikungunya, the really standout feature is severe arthralgia, intense, sometimes crippling joint pain.
Right. I've heard about that with chikungunya.
Yeah, it can be really bad. And then Zika, often a rash with pruritus, so an itchy rash is more common. These subtle differences, they're crucial for guiding that initial clinical judgment when you don't have the labs back yet, or maybe won't get them.
That makes a lot of sense. Having those clinical pointers is key. So before we get into treatments, how do the guidelines classify how sick someone is? What's the split between non-severe and severe?
It's a very practical distinction. Severe disease basically means you need hospitalization. That decision's based on the clinical evaluation, looking for specific warning signs, or if the patient already has complications. Non-severe disease is, everything else. Cases that can typically be managed safely outside the hospital as an outpatient, and this distinction is vital, especially during big outbreaks when hospitals can get overwhelmed. It helps direct resources effectively.
Got it. So for someone at home feeling sick, what are those warning signs that mean get to a hospital now?
Good question. For dengue, which is often the main focus here, the key warning signs are things like severe abdominal pain, especially if it's getting worse or just won't go away. Also, changes in mental state, like being really irritable or unusually sleepy, lethargic, any bleeding from the gums, nosebleeds, unusual heavy periods in women, that's mucosal bleeding.
Okay.
And enlarged liver, what doctors call hepatomegaly, specifically if it's palpable more than 2 centimeters below the ribs. Persistent vomiting is another big one, like 3 or more times in an hour or 4 times in 6 hours.
Right.
And clinically, if blood tests show the hematocrit is rising progressively, these are all red flags demanding immediate medical help. For Zika, chikungunya, yellow fever, it's a bit more about the individual clinical picture, looking for signs of specific severe complications rather than one universal set of warning signs like dengue.
Okay, that's clear. Let's talk treatment then. For those non-severe cases managed at home or as outpatients, what do the new guidelines recommend?
The focus for non-severe is really on simple, accessible, low-cost things, especially because, again, you might not have that lab confirmation early on. Oral rehydration is key, and the WHO is actually suggesting protocolized oral fluid treatment. It's a conditional recommendation, but it's a specific one.
Protocolized. So not just drink plenty of fluids, but something more structured.
Exactly. It means actively managing it, using a measuring cup, keeping track of how much fluid goes in. The aim is ensuring proper hydration to prevent dehydration, which might help keep people out of the hospital. Practical advice includes frequent small sips, aiming to pass urine, 4 to 6 times a day.
Okay. And what kind of fluids? Just water?
Water's primary, yeah. But things like soups, coconut water, locally available options are fine too. What's critical, though, is to avoid commercial fizzy drinks and sweetened teas. The high sugar content can actually make things worse.
Good tip. What about managing symptoms like fever and pain?
Right, symptom control. The guidelines suggest paracetamol, that's acetaminophen for pain and/or fever. Again, it's a conditional recommendation. It's widely available, cheap. Its actual benefit wasn't fully pinned down in the review, but it's considered safe at the right doses. Just need caution if someone has pre-existing liver problems.
Makes sense. Standard advice often.
Pretty standard, yes. Then there's metamizole, also called dipyrone, also suggested conditionally for pain and fever, but, and this is a big but, its availability and approval vary hugely around the world. Some places have even banned it.
Why is that?
Because of a rare but very serious side effect called granulocytosis, a big drop in white blood cells. So if it is available and approved where you are, it's an option. Its fever reduction is similar to NSAIDs. But speaking of NSAIDs, this is a major point. Non-steroidal anti-inflammatory drugs, think ibuprofen, aspirin. The WHO makes a strong recommendation against using NSAIDs for any suspected or confirmed arboviral disease. Doesn't matter if it's severe or not.
Wow, a strong recommendation against. That seems quite definitive, especially for common drugs like ibuprofen. Why so strict?
It is definitive. Even though they can lower fever, the expert panel was really concerned about how they affect platelets. They have an antiplatelet action. And that increases the risk of severe bleeding, particularly in dengue, where platelet counts can already be dangerously low.
Okay, the bleeding risk.
Exactly. So in that acute phase, when you might not know for sure if it's dengue or something else, safer options like paracetamol are preferred. There are tiny exceptions, like someone already taking NSAID long-term for arthritis, or maybe for the specific joint pain in confirmed chikungunya. But generally, avoid them. It stresses why diagnosis matters.
That's a really crucial takeaway. What about corticosteroids?
For non-severe cases, the WHO suggests against using systemic corticosteroids. The evidence for benefit is just very low certainty, and there are potential harms, immunosuppression, maybe gastrointestinal bleeding. So generally, no. If someone's already on them for another condition, that's an individual decision with their doctor.
Okay, so that covers non-severe. Now, let's shift to the patients who are hospitalized, the severe cases. The stakes are much higher. What are the key recommendations there?
Right. In the hospital, it's all about careful fluid management and advanced monitoring to support vital organs. First, the type of IV fluid. The WHO suggests using crystalloid fluid, things like Ringer's lactate or normal saline, rather than colloid fluid. This is a conditional recommendation.
So crystalloids over colloids. Is it that colloids don't work as well, or are they riskier?
Well, the evidence didn't show a clear benefit for colloids in terms of major outcomes like mortality or organ failure, but they might increase the risk of severe adverse events like infusion reactions. Plus, they're usually more expensive and less available globally.
Ah, the equity issue too.
Exactly. So prioritizing crystalloids is seen as safer, more accessible, and likely just as effective. It's pragmatic. Now, guiding how much fluid to give, that's where monitoring comes in. And this is a really dynamic area in the guidelines. There's a strong recommendation for using capillary refill time, or CRT.
CRT, that's the finger press test, right? Seems simple. Why is it so strongly recommended for something as critical as IV fluids?
Yes, it's that simple visual test. Press the fingernail or fingertip, see how fast the color returns. Longer than 3 seconds is abnormal. It's strongly recommended because, despite its simplicity, it's a good indicator of end organ perfusion, how well blood's getting to the tissues. And importantly, studies show that guiding fluid resuscitation using CRT is non-inferior, basically, just as good as using more complex lactate measurements when it comes to mortality.
Wow.
Yeah, it does need proper training to do it accurately, but because it's non-invasive and needs no equipment, it's incredibly feasible, especially in low-resource settings.
Makes sense. You mentioned lactate, though. Is that also recommended?
Yes, there's also a strong recommendation for using lactate measurement in addition to standard care.
Okay, so what does lactate tell us? Why is that important, too?
Lactate levels go up when tissues aren't getting enough oxygen, indicating anaerobic metabolism. Higher lactate levels are linked to worse outcomes. Using lactate monitoring probably decreases mortality compared to just standard care or other monitoring. The caveats are, again, availability. Not all settings have easy access to lactate testing. And critically, it's unreliable in liver failure.
Which can happen in yellow fever, right?
Precisely. So you can't rely on lactate alone if the liver is failing, which is common in severe yellow fever. Context matters. Then there's the passive leg raise test, or PLR. This gets a conditional recommendation. The WHO suggests using it when a patient is in shock, and the clinicians aren't sure if giving more IV fluid will actually help.
A physical test to guide fluids. How does lifting someone's legs help decide that?
It's quite clever, actually. It's a dynamic test. You measure the patient's cardiac output, then quickly lower their upper body and raise their legs to 45 degrees. This shifts blood from the legs to the central circulation, temporarily mimicking a fluid bolus. If their cardiac output jumps up immediately by more than about 10%, it strongly suggests they are fluid responsive, meaning giving them more IV fluids will likely improve their circulation.
So it predicts who will benefit from more fluids without the risk of giving fluids to someone who won't benefit or might even be harmed by overload.
Exactly. It helps avoid unnecessary fluid administration. The big limitation, though, is that it requires real-time cardiac output monitoring. Usually that means ultrasound, which isn't always available and needs specific training.
Got it. What about other treatments in severe cases? Corticosteroids, immunoglobulins.
Similar story to non-severe cases, really. For corticosteroids, still a conditional recommendation against their routine use in severe arboviral disease. Very low certainty of benefit, ongoing concerns about harm. May be considered for specific complications like myocarditis or encephalitis, but case by case, and immunoglobulins like IVA, also a conditional recommendation against. Just not enough evidence they help, plus they're expensive and scarce. Better safe for conditions where they are proven to work, like Guillain-Barré syndrome.
Okay. Now, platelets. This was surprising in the non-severe context. What about for severe cases with low platelets? Surely transfusions are needed then.
This is another area where the guidelines might challenge older practices. The WHO makes a conditional recommendation against prophylactic platelet transfusion, even in severe cases if the platelet count is low, say under 50,000, but the patient isn't actively bleeding.
Still against it, even if they're severely ill and platelets are low, as long as there's no active bleed. I think many would assume a transfusion is automatic then.
It's a common assumption. But the evidence review found that while thrombocytopenia is common, especially in severe dengue, significant spontaneous bleeding, just because of the low platelet count, is less frequent than feared. And there's no clear proof that giving platelets prophylactically actually prevents bleeding or improves outcomes. Plus, transfusions carry risks, fluid overload, infections.
So transfusion only if there's actual bleeding or maybe before surgery.
Correct. Active significant bleeding warrants transfusion, or if an invasive procedure is absolutely necessary, but not just for the number alone. It's a significant shift towards a more conservative, evidence-based approach.
Really interesting. Now let's focus specifically on yellow fever. You mentioned it causes liver failure. Are there any specific treatments recommended, even conditionally?
Yellow fever is tough because effective treatments are lacking. The guidelines highlight a couple of interventions, but stress they are primarily for research settings due to limited evidence. One is N-acetylcysteine, or NAC. There's a conditional recommendation suggesting its use intravenously, specifically for liver failure caused by yellow fever.
NSC. Isn't that the antidote for paracetamol or acetaminophen overdose? Why suggest it for yellow fever?
Yes, that's its main proven use. The suggestion for yellow fever liver failure comes from looking at evidence, albeit very low certainty evidence, from its use in other types of acute liver failure. Given how severe yellow fever liver failure is, and that NSC is relatively safe and low cost, it's put forward as a pragmatic option. But, and this is crucial, its use for yellow fever must not compromise its availability for patients who definitely need it for paracetamol overdose. That highlights a real resource dilemma in global health.
A difficult balance. What about other potential treatments?
Two others are mentioned, a monoclonal antibody called TY01SAR and sofosbuvir, which is an antiviral used for hepatitis C.
Another flavivirus, like yellow fever.
Right. But for both TY014 and sofosbuvir in yellow fever, the recommendation is clear. Only use them in research settings. There just isn't enough data from human yellow fever patients yet to support their routine clinical use. We need proper clinical trials. Ideally, these trials would happen during outbreaks, perhaps using frameworks like MURI, that's the Monitored Emergency Use of Unregistered and Investigational Interventions framework.
So promising candidates, but still need rigorous testing before they can be recommended for general use.
Exactly. There's a huge need for effective yellow fever treatments, driving the push to evaluate these, but the evidence has to come first.
These guidelines are incredibly detailed and seem very evidence-focused. Can you give us a sense of how they were actually put together? What's the process?
It was a really rigorous process, following the standard WHO methods for developing trustworthy guidelines. They convened a guideline development group, the GDG. This wasn't just lab researchers, it was multidisciplinary clinicians, epidemiologists, methodologists, experts from different regions, and importantly, patient representatives were included too.
Patient representatives, that's great to hear.
Yes, ensuring the patient perspective was considered. They used the GRADE methodology, grading of recommendations, assessment, development, and evaluations, to systematically review the evidence for each question and assess its certainty. That's why we keep mentioning low or very low certainty evidence for some recommendations. It reflects the quality and quantity of the available research.
So a big shift from just relying on expert opinion, really grounding it in the available science.
Absolutely. Earlier guidance often leaned more heavily on expert consensus. This update was specifically driven by the need for a global evidence-based approach. It also builds on important regional work, like the PAHO guidelines developed in the Americas. It's a more systematic, transparent process.
That makes sense. Looking ahead then, what did the guideline development group identify as the biggest gaps? What research is most urgently needed?
They flagged several critical areas. A big one is understanding disease progression, better finding reliable biomarkers to predict early on who is likely to go from non-severe to severe disease. That'd be huge. Also, refining fluid management, more research comparing different types of crystalloid fluids, and figuring out the best way to combine different monitoring tools like CRT and lactate in practice. On the therapeutic side, properly evaluating corticosteroids in severe dengue is still needed, understanding the specific mechanisms of shock in chikungunya. And for yellow fever and Zika, really pushing forward those clinical trials for antivirals and monoclonal antibodies. And a cross-cutting theme was the need for more inclusive evidence, making sure future studies actively include populations often left out: children, pregnant women, people with compromised immune systems. Their needs might be different.
That's a comprehensive research agenda. It really underscores that this is an ongoing process. This deep dive has been incredibly insightful. It really shows how dynamic global health is and how these guidelines provide a vital evidence-based framework. Thinking back on our conversation, what really stands out to you? For me, it's maybe how something seemingly small, like avoiding NSAIDs, can be so critical, or how that simple CRT test can guide life-saving decisions.
I think what's fascinating is seeing that constant interplay laid bare. The scientific evidence, sometimes strong, sometimes limited, balanced with practical clinical judgment and the realities of resource availability across the globe. These guidelines aren't set in stone. They're a snapshot of our best understanding right now, a testament to this continuous global effort to do better against these threats. And it shows that even with really complex diseases, these focused, evidence-driven strategies can make a real difference.
So here's a final thought for you, our listeners. As our world changes, as temperatures shift and these mosquito vectors potentially expand their reach, how will the ongoing evolution of guidelines like these keep pace? And maybe more personally, how can staying informed, supporting research, and promoting awareness help us all collectively stay ahead of these microscopic but truly significant global health threats? Keep asking, keep learning. We'll be here to continue the deep dive.